Welcome back to the deep dive. Today we are opening up chapter 27 of Human Anatomy, diving right into the reproductive system.
A big one.
A very big one. You sent us this material, and our mission is, well, to give you the most efficient shortcut possible, a guided tour, really, through every major structure, cycle, and clinical note.
Right.
We're going to try and help you visualize all of this without ever needing to look at the textbook figures.
And, if we had to capture the theme of this whole chapter, it really boils down to a massive logistical contrast.
Okay.
The shared purpose is clear, right? Produce and unite gamete sperm and ova to form a zygote. But the male system is, it's engineered for industrial output. We're talking nearly 500 million sperm a day.
500 million, wow.
Every single day. The female system, though, is built for precision. It typically nurtures and prepares just one single oocyte per monthly cycle. So you've got scale versus absolute precision.
That's a great way to frame it. Okay, let's unpack this then, starting with that mesoscale, the foundations of the male system. So we're talking about the gonads, the testes, this long series of transport ducts, the epididymis, accessory glands, and of course the external genitalia.
And we have to start with the testes. They're these flattened egg-shaped organs, about 5 centimeters long, and they hang externally in the scrotum. The very first question is, why are they external?
Right. How did they get there?
Exactly. They actually develop way up high in the body cavity, near the kidneys.
Yeah.
This means they have to descend during fetal development.
When does that happen?
It's pretty late, around the 7th developmental month.
And what actually pulls them down? It sounds like a pretty complicated journey.
It is. It's largely driven by a tough connective tissue cord called the gubernaculum testis.
The gubernaculum.
Right. It essentially contracts and stimulates the testes to migrate down through the abdominal muscles and into their final spot in the scrotal chambers. And when this happens, they don't just, slide through. They drag layers of everything with them. Fascia, muscle, blood vessels.
And I'm guessing those layers they drag down become really important later on?
Absolutely. They form the spermatic cords. These are basically dense protective sheaths that house all the vital infrastructure.
So what's inside?
You've got the ductus deferens for sperm transport, the testicular artery, and a really critical vascular network called the pampiniform plexus.
The pampiniform plexus. That's a term that always sounds so much more complicated than it needs to be.
It does, but think of it simply as a biological radiator system.
A radiator?
Yeah, it's a dense web of veins that surrounds the artery. The veins have cooler blood flowing away from the testes, and they act as a heat exchanger, cooling down the warmer arterial blood that's flowing to the testes.
Ah, so it's all about temperature.
It's all about maintaining that precise temperature balance. And these spermatic cords, they have to pass through the inguinal canals.
Which is why we hear about inguinal hernias so often in males, right? It's a weak spot.
Precisely. The inguinal canals are these narrow passageways that link the scrotum to the abdomen. And because they're the path of descent, they just remain a permanent structural weak point.
Speaking of temperature, let's zoom in on the scrotum itself. It's marked externally by that line, the perineal raphe, and it's divided into 2 chambers inside.
Right, and it has 2 key muscle layers for control. First, right under the skin is the dartos muscle. It's smooth muscle.
So slow contractions.
Slow tonic contractions. It causes the skin to wrinkle, which pulls the whole structure a bit closer to the body. It just minimizes heat loss.
And then there's the fast-acting one.
That's the deeper cremaster muscle, which is skeletal muscle. This one controls the rapid cremastric reflex.
And this is all because normal sperm development needs that very specific temperature, something like 2 degrees Fahrenheit lower than body temp.
Exactly, 1.1 degrees Celsius lower. If the temperature drops, the cremaster reflexively snaps the tests up against the body. If it gets too warm, it relaxes and lets them drop away to cool down. It's a beautifully simple, tuned system.
Okay, so that's the external control. Let's move inside the testes to the factory floor, as you put it. It's covered by that tough, fibrous capsule, the tunica albuginea.
And the tunica albuginea sends these projections inward, called septa. They divide the testis into hundreds of little compartments, or lobules.
And inside the lobules is where the real magic happens.
That's where you find the core machinery, the seminiferous tubules.
And there are a ton of them.
An incredible amount, about 800 per testes, which adds up to nearly half a mile of coiled tubing if you stretched it all out.
Wow.
This is the exclusive site of spermatogenesis. From here, the path is seminiferous tubules into straight tubules, then into a maze called the rete testes, and finally out through the efferent ductules.
So that's the assembly line, but who's running the factory? That would be the cells around the tubules, the interstitial cells, or cells of Leydig.
They're the CEOs of the process. They produce the essential hormones, the androgens, primarily testosterone. And testosterone's role is huge. It stimulates spermatogenesis, maintains the accessory organs, drives secondary sexual characteristics. It's the master hormone here.
Okay, if the Leydig cells, or the hormone-producing CDOs, then the nurse cells, or Sertoli cells, they have to be the factory floor managers.
A perfect analogy. Because while meiosis produces 4 haploid spermatids from one primary spermatocyte, those spermatids are useless until they mature into functional spermatozoa.
And that's called spermatogenesis.
Right. And that maturation process is entirely managed by the nurse cells. But their most vital job is maintaining the blood-testis barrier.
Why is that barrier so absolutely critical?
Well, because sperm cells, once they undergo meiosis, are genetically different.
Yeah.
They express antigens that the male's own immune system would see as foreign.
So the body would attack its own sperm.
It would launch a massive attack and sterilize the male. The nurse cells form tight junctions, creating an immunological wall to protect the developing sperm at all costs. It's a fascinating evolutionary compromise.
Let's talk about that final product, the spermatozoa. It's basically a torpedo designed for one mission. You've got the head, which is just a packet of DNA.
And it's topped by the acrosomal cap. Think of it as a warhead filled with the digestive enzymes needed for fertilization.
Then there's the engine, the middle piece.
Packed with mitochondria in a tight spiral. This is what generates all the ATP to power the tail, which is a single flagellum. It moves in this complex corkscrew motion.
And the key weakness here is that they don't carry their own fuel.
No, they have no energy reserves. They have to absorb nutrients, specifically fructose, from the seminal fluid to get anywhere.
Okay, so once they're produced, they enter the duct system, starting with the epididymis. You said this thing is 7 meters long.
It's incredible. 7 meters of highly coiled tubule. It's where they monitor the fluid, recycle damaged sperm, and store the new ones. But most importantly, it's where the sperm spend 2 weeks functionally maturing.
But they're still kept dormant there, right? They're not ready to fertilize an egg just yet.
That's correct.
Yeah.
They are actively prevented from undergoing capacitation. That's the 2-step process that makes them fully motile and able to fertilize. The epididymis is like the safety lock.
And the path continues from there through the long ductus deferens, or vas deferens, which expands into the ampulla before meeting the ejaculatory duct, which then empties into the urethra.
And all along this final part of the journey, the accessory glands add their fluids, which make up about 95% of the final semen volume. These are crucial for activating the sperm, feeding them, and buffering against acidity.
Let's quickly run through the 3 major glands.
First, the seminal glands. They contribute the most, about 60%. Their fluid is high in fructose for energy, and it's what makes the sperm highly mobile. It's the activation fluid.
Then the prostate gland.
It adds about 20 to 30%. It's a weakly acidic fluid, but it contains an antibiotic called seminal plasmin, which helps prevent urinary tract infections.
And last, the little guys.
The paired bulbo-urethral glands, or Cowper's glands. They add the initial pre-ejaculate fluid. It's a thick alkaline mucus that neutralizes any residual urinary acids in the urethra and provides lubrication.
And we wrap up the male anatomy with the penis. You have the root, the body, and the glands, and its structure is mostly 3 columns of erectile tissue.
2 superior corpora cavernosa and the single corpus spongiosum below, which surrounds the urethra. And the release of semen is a 2-step sequence.
Emission and ejaculation.
Right. Emission is first. That's the sympathetic nervous system mixing all the fluids. And it's immediately followed by ejaculation, the powerful expulsion driven by rhythmic muscle contractions.
And before we move on, a quick but important clinical note from the text: testicular cancer.
Yes, it's tragically the most common cancer in younger men, ages 15 to 34, and it often arises directly from those sperm-producing cells.
Okay. With the industrial scale of the male system mapped out, let's pivot to the system of precision and nurturing, the female reproductive system.
Its mission is, so much broader, not just producing the gamete, but protecting and supporting the embryo and then nourishing the newborn.
The major structures here are the ovaries, uterine tubes, the uterus, and the vagina, and they're all sort of anchored by this huge sheet of tissue, the broad ligament.
Yes, the broad ligament is the primary support mesentery. We also have other stabilizers like the ovarian and suspensory ligaments, and anatomically this creates important landmarks, specifically 2 peritoneal pockets, the rectuterine pouch and the vesicouterine pouch.
So let's look at the ovaries. covered by the tunica albuginea and germinal epithelium. And all the action happens in the outer layer, the cortex.
This is where oogenesis takes place.
Yeah.
And unlike in males, this process actually begins before birth.
Before birth.
Yes. Then it's held dormant until puberty. Once it's activated, we get the monthly, highly choreographed ovarian cycle driven by FSH. And there are 6 critical stages here.
Walk us through them. Where did the hormones really kick in?
It starts when primordial follicles develop into primary follicles. This is the key site for hormone production. The oocyte is surrounded by layers of granulosa cells and the zona pellucida. Then the nearby the epididymal cells cooperate with the granulosa cells to just crank out high levels of estrogens, mostly estradiol.
And these rising estrogens are the signal to the rest of the body.
Exactly. Estrogens do a ton of things, like stimulating bone and muscle growth, but crucially they start the repair and growth of the uterine lining to get it ready. As these follicles mature, they become secondary follicles, and then one dominant follicle becomes the tertiary follicle.
And the tertiary follicle is the tipping point.
It's the moment of commitment. This big follicle, it bulges on the surface of the ovary, and inside, the primary oocyte finally completes meiosis the first. This produces a tiny, non-functional polar body and the large, functional secondary oocyte.
The system is now primed for the main event, which is triggered by a huge hormonal surge.
That's the sudden, massive LH surge from the pituitary, usually around day 14. This surge weakens the follicular wall, and that leads to ovulation, the release of the secondary oocyte, still wrapped in its protective corona radiata, into the pelvic cavity.
And what about the huge follicular shell that's left behind?
The empty follicle collapses, and under that continued LH stimulation, it transforms into a temporary endocrine gland called the yellow corpus luteum.
And its whole job is to make progesterone.
Exactly. It secretes progestins, mainly progesterone, which is the hormone that stabilizes and sustains that thickened uterine lining, making it perfectly receptive to a pregnancy.
But if fertilization doesn't happen,
If there's no pregnancy signal, the corpus luteum just degenerates. It involutes, turning into scar tissue called the corpus albicans.
and when that happens, the hormone levels plummet.
They plummet. Progesterone and estrogen crash. And that drop is the signal for the hypothalamus to release GnRH, which tells the pituitary to start the whole next cycle with FSH and LH. That drop triggers menstruation.
So let's follow that oocyte after ovulation. It enters the uterine tubes, about 13 centimeters long. You have the funnel-shaped infundibulum with its little feathery fimbriae,
Right.
which lead to the wider part, the ampulla. And the ampulla is so important because it's the usual site of fertilization. And the timing here is everything. The oocyte has only a 12 to 24-hour window to meet sperm.
And the transport itself takes a few days.
About 3 to 4 days, yeah. It relies on cilia and peristalsis to move the oocyte toward the uterus.
And the uterus itself is a pear-shaped organ normally bent forward over the bladder in a position called anteflexion. Internally, you have the main body, the rounded top or fundus, and the narrow part that projects into the vagina, the cervix. Structurally, the uterine wall has 3 distinct layers. The outer layer is the perimetrium. The massive middle layer is the myometrium, 90% smooth muscle. That's the incredible force for childbirth.
And the inner layer, where all the monthly action happens, the endometrium.
Correct. And the endometrium itself is subdivided. You have the deep, constant basilar layer, and then the highly vascular functional layer. It's a functional layer that grows and sheds every single month.
Which brings us right to the uterine cycle, or menstrual cycle. Perfectly synchronized. Phase 1 is menses.
Menses is simply the destruction and sloughing off of that functional layer because the ovarian hormones have declined. This lasts 1 to 7 days. Then it transitions into the proliferative phase.
And this is driven by estrogen.
Right. Rising estrogen from the developing follicles stimulates the rapid repair and thickening of that functional layer.
And then finally, after ovulation.
You enter the secretory phase. This lasts a steady 14 days. It's maintained by high levels of progestins and estrogens from the corpus luteum. Glands swell, secretions ramp up, and the crucial blood supply, the spiral arteries, elongate, preparing the perfect environment for implantation.
And if that doesn't happen, the spiral arteries constrict, and we're right back at menses.
The whole cycle starts again. We mark the beginning of these cycles as menarche and the end as menopause.
Right. And below the uterus, the vagina is an elastic muscular tube. Its environment is naturally acidic, which is why those alkaline seminal buffers are so essential for sperm survival.
Exactly.
And for the external genitalia, or vulva, the key takeaway here is really the structural homology with the male system.
Yes, the parallels are so clear. The vestibule is enclosed by the labia minora. The small erectile clitoris is homologous to the male corpora cavernosa. The outer folds, the labia majora, are homologous to the scrotum, and the lubricating greater vestibular glands are homologous to the male bulbo-urethral glands. It's the same basic blueprint, just adapted for very different roles.
We'll finish the anatomy with the accessory organs for nursing, the mammary glands. Internally, the glandular tissue is organized into lobes and lobules, which drain into lactiferous ducts and then a lactiferous sinus near the nipple.
And their function is purely hormonal. Development is driven by prolactin, growth hormone, and HPL during pregnancy. And the actual milk ejection is a reflex driven by oxytocin, which is triggered by infant suckling.
The clinical notes in this chapter are really important, highlighting the prevalence of several cancers.
We have to give them space. The text notes ovarian cancer has a high mortality rate. Uterine cancers are divided into endometrial cancer, often in the 50 to 70 age group, and cervical cancer, which is a primary risk factor in HPV infection.
And that's why the pap smear is so important.
Absolutely, for screening those abnormal cells.
And then there's breast cancer, still the primary cause of death for women in the 40 to 59 age group. Detection there relies on mammography.
These are powerful reminders of why this anatomy matters.
And finally, let's touch on the differences in aging. Menopause in females is pretty sudden, right?
Relatively sudden, yeah. Usually between 45 and 55, ovulation and menstruation just cease. The rapid drop in estrogen and progesterone causes a big compensatory spike in GnRH, FSH, and LH, which leads to things like osteoporosis and hot flashes.
But the male experience, the male climacteric, is much more gradual.
Far more gradual. Usually starts around 50 to 60. Testosterone slowly declines, FSH and LH rise, but sperm production often continues well into old age. That difference in pace really speaks to the original design. The system built for scale just slows down. The one built for precision shuts off.
That's a great summary. We've covered this huge range, from that 7-meter epididymis to the synchronized uterine cycle.
And the critical importance of things like the blood-testes barrier.
And to wrap up, let's circle back to that coordination. We learned the corpus luteum is only essential for the first 3 months of pregnancy. Then the placenta takes over the endocrine role entirely.
That shift is one of the most remarkable bits of physiological integration. So here's something to think about. Why is it so essential for the fetus that the placenta becomes the hormone factory? And how does the placenta's vast steroid-producing capacity actually differ structurally and functionally from the short-lived corpus luteum it replaces?
That is the perfect question to end on. It's a great thing to mull over as you integrate all this.
For sure.
Thank you for providing the material for this incredibly dense but essential deep dive. And from the Last Minute Lecture team, thank you for listening.